Good evening. Welcome to Kennedy Krieger Institute's Exploring the Brain webinar, Understanding Pediatric Feeding Disorders. I'm Lisa Nickerson, and we're delighted you've joined us this evening as we discuss childhood feeding problems and disorders and strategies to address these roadblocks in a child's eating journey. And we'll provide information about when an evaluation for a feeding concern with a medical professional might be appropriate. Kennedy Krieger is a nonprofit organization, and our nearly 3,000 staff members are proud to serve more than 27,000 children with neurological disorders, injuries, and diseases, and their families each year. Our Pediatric Feeding Disorders Program staff offer inpatient, outpatient, day treatment, and evaluation programs, and is one of nearly 90 programs and clinics at the Institute. But now a bit about tonight's live interactive webinar and how it might work. If you have a question that doesn't get answered during the discussion with our panelists, please use that Q&A tab that's likely at the top of your Zoom screen to post a question for the panel to address at the end of the panel discussion. We will answer as many questions as time will allow, often grouping questions together by topic. There will be a screen at the end of the presentation with a web address and phone number for the Feeding Disorders Program at Kennedy Krieger, and you'll receive information later by email for other resources as well. Our moderator for this evening's webinar panel is Dr. Brad Schlager. Brad Schlager is a pediatric neurologist and president and CEO of Kennedy Krieger Institute. Dr. Schlager's been at the helm of Kennedy Krieger for more than 5 years, where he's the proud leader of the nearly 3,000 folks that we mentioned, who are supporting and caring experts and professionals in many realms of child development, education, and neurological health. I'm joined by Dr. Schlager now, who will introduce our panel of feeding experts. Welcome, Brad.
Thanks, Lisa, and welcome, everyone. Feeding is remarkably complex. Even though it feels so automatic, successful feeding requires a whole host of different systems in the body to function in a coordinated fashion. Those systems include the nervous system, musculoskeletal, gastrointestinal, cardiopulmonary, and others. During development, whether due to a congenital or acquired condition, if one or more of these systems is not functioning correctly, odds are increased that a pediatric feeding disorder will emerge and persist. Regardless of the cause, a child with a feeding disorder does not consume enough calories, nutrients, or fluids to meet their nutritional needs and maintain their growth and overall health. That child also may not eat in age-typical ways, which can in turn impact that child's social development. And because so many medical and developmental issues can contribute to a feeding disorder, the most successful models of treatment rely on an interdisciplinary approach. So in this interactive webinar tonight, through the collective expertise of our panelists, all from Kennedy Krieger Institute's Feeding Disorders Program, you'll see why that interdisciplinary approach is critical for effective diagnosis and treatment. So joining me tonight, we have an expert panel that includes Dr. Michelle Malacosta. She's a pediatrician who serves as the medical director of Kennedy Krieger's Pediatric Feeding Disorders Program. Dr. Malacosta is also the Associate Chief Medical Officer at the Institute. Christina Keeney is a family nurse practitioner in the Institute's Pediatric Feeding Disorders Program. Katie Davis is a registered dietitian and certified lactation counselor who works with patients of all ages and their families on all levels of the feeding processes at Kennedy Krieger. Katie Stevens is a senior occupational therapist at Kennedy Krieger's Pediatric Feeding Disorders Program, who works with children of all ages in both inpatient and outpatient settings. Jennifer Del Rey is a speech-language pathologist and certified lactation counselor at our Feeding Disorders Program and also supports our Tethered Oral Tissues, or TOTS, clinic. Jen also serves as a director-at-large speech-language pathologist for the International Association for Pediatric Feeding and Swallowing. And finally, Dr. Sarah Haney is a doctoral-level board-certified behavioral analyst and senior behavioral analyst in the Kennedy Krieger's Feeding Disorders Program. So welcome, everyone, and let's dive right in. We'll start with you, Michelle. What's a pediatric feeding disorder, and how does it differ from, say, picky eating?
Thanks. So just as you mentioned, a child with a feeding disorder doesn't take in enough calories and nutrients to stay healthy. In contrast, going through spells of picky eating can be expected as part of many children's typical development. Feeding skills develop along with both motor and interpersonal or social skills. So, right from birth, infants are interested in others' faces. They'll watch the adults around them eating. And starting as early as 2 months, they'll open their mouth if you bring a spoon to it. That doesn't mean they're ready to eat solid food yet. That depends on them developing good head control, which happens at around 4 to 6 months. In the next few months after that, they have their highest acceptance of new tastes. That usually happens in the 6 to 9 month range. By around a year of age, again, feeding being a very social aspect to it that's very interpersonal, they'll start pointing to foods they like to share, to let the adults around them know what they want. And by about 15 months, they'll be imitating adult eating behaviors and preferences. But then something often happens. Just as those toddlers begin to become more independent walkers, they also show an increased aversion to new tastes, especially tastes that have any bitterness to them. We call this food neophobia, and it occurs across cultures all over the world, which suggests that neophobia evolved as a protective mechanism. So, right at the age where children can walk away from their protective parents, they become less likely to want to ingest something that they haven't ever seen before, avoiding eating something that could poison them. Neophobia peaks at around age 2 and typically responds to repeated positive exposures. By age 4, most kids are eating a pretty typical diet compared to their family and age peers. So, picky eating is thus a pretty common parental concern. At least 30% of preschoolers at some point have parents come to their pediatrician saying, gee, my kid's really a picky eater. And generally, it's going to resolve on its own by school age. So, when it becomes a feeding disorder is when that child restricts what they eat to a degree that it starts to affect their health, their growth, and also the social aspects of eating. So, if they can't eat what their peers eat, or they won't eat in situations that are typical for their peers or family, like the family can't go out to a restaurant, that would be socially, developmentally unusual. But the biggest red flag for me is when a child isn't growing well or has other health concerns.
Michelle, staying with you, feeding disorders and eating disorders, they sound similar. And I'm sure there are some on the webinar who are wondering, what's the distinction? Are they the same? Can you tell us, disambiguate those two things?
Yeah, no, they're quite different. So a child who has a feeding disorder is certainly restricting what they eat, but it's due to selectivity around taste or texture, or perhaps oral motor discomfort, weakness in their chewing or swallowing that makes them not want to eat those foods. Someone with an eating disorder always has what we call body dysmorphia, meaning an inaccurate sense of their body image. And so they're restricting food specifically to reduce calories or eliminate fat. So they're very different.
A very important distinction, yes. So Christina, turning to you, are there some underlying conditions or diagnoses, we would say etiologies, that increase the risk for a child to develop or have a feeding disorder?
Yes. So as part of our multidisciplinary evaluation, we're going to take a detailed medical history to look at what the cause may be, as there are many potential risk factors for a child to develop a feeding disorder. For example, any issue that delays a child from learning to eat orally places them at risk. And this could include such things as prematurity, an extended hospital stay, history of intubation, multiple surgeries, and/or placement of a feeding tube. Other potential causes include neurodevelopmental diagnoses, such as epilepsy or autism spectrum disorder, where a child may be rigid or repetitive with their narrow diet, Down syndrome, a disorder that may impact tongue movement or chewing skills, or cerebral palsy, where low tone, muscle weakness, and/or gross motor delays may place that child at risk of aspiration, or where the food or the liquid goes down the wrong tube. It's important to note that not all children have a cause for their feeding problems. It is a possibility that a neurotypical child could have no underlying cause. In these cases, their oral aversions may have turned behavioral over time. Lastly, please note that this list is not all-inclusive, and certainly there is a relationship between the characteristics of a pediatric feeding disorder. And just to briefly recall, those are medical, nutritional, feeding skills, or psychosocial dysfunction, meaning that impairment in one area can lead to dysfunction in any of the other areas.
So at the front end, I mentioned the interdisciplinary approach. So I think it'd be helpful if we talked about what each discipline brings to the pediatric feeding disorders program. So I'm going to ask each of you to answer this question. What is the role of your discipline? Let's start out with Michelle.
Thanks. So medicine's role, as Christina mentioned, part of our role is to evaluate for any underlying diagnoses that might be contributing to that child's refusal to eat, as well as monitoring their health during feeding therapy. To illustrate the different roles that each of us takes, we'd like to introduce a patient as an example. We're going to call her Allison. She was a 6-year-old little girl who admitted to our inpatient feeding program. Allison had been born prematurely. She was 32 weeks gestation and had many complications that led to her having to remain in the neonatal ICU for 8 months. Due to her severe underlying lung disease, she was not able to try eating by mouth until really late in her NICU stay. And so she missed some of those key developmental windows, as I mentioned earlier, when babies are learning, for example, how to use their tongue to move purees to the back of their mouth, excuse me, to swallow, and those ages when babies are most receptive to new tastes. So after she left the NICU, she was offered small amounts of foods, but she had a lot of gagging, and she never accepted them very readily. By age 5, she was still dependent on a G-tube, on gastrostomy feeds that had been placed when she was an infant in the NICU. Her parents had had attempts to advance solid foods, and these had resulted in refusal and weight loss. Medically, she exhibited a lot of gastroesophageal reflux, and the team was concerned that she was at risk for aspiration, where those reflux contents could get into her lungs. Given her underlying lung disease, we wanted to be especially protective about any risks to her lung health. So part of medicine's role in a case like hers was careful daily monitoring, not only of her weight and her fluid intake, but also her lung exam, her vital signs, and her overall well-being, including adjusting medications as needed to support her success with the feeding program.
Got it. So Katie, you're up next. Let's discuss the role of nutrition.
Yeah, so nutrition is on the team to evaluate and ensure that a child is meeting their nutrition needs before, during, and after feeding therapy. So when I say nutrition needs, I'm talking about calorie needs, micronutrient needs like vitamins and minerals, and then fluid needs. We are also here to help support the team avoid any allergens or foods that can cause GI distress for the patient. So in the case that we're referring to, my primary role was to adjust tube feeds, really to make room for the child to eat more by mouth. This child did not have a lot of what I would call nutritional reserves. And so we had to be careful, right? We want to make sure that the child is hungry for therapy, but also has enough energy to learn this brand new important skill of how to eat.
Jen, let's turn to the role of oral motor skills in feeding disorders.
Yeah, so speech language pathologists and occupational therapist roles overlap on our team. So during this case specifically, we work together to assess oral motor skills like chewing and spoon feeding, positioning as it related to feeding, self-feeding, and monitoring safety within meal times. Due to all of those medical complications that Michelle discussed, this particular patient did not move through the developmental feeding milestones that we would expect. So she came to us only eating small tastes of purees, which really limited her experiences with solids and liquids, which are necessary to develop those skills that we need for eating. As her treatment progressed, she did show signs of aspiration, so food and liquid kind of going down the wrong pipe. We saw coughing, wet vocal quality, So we recommended a swallow study and then made recommendations based on that test. We worked together with our team to maximize safety across meal times and behavioral psychology meals. Specifically with us, we focused on foundational skills for chewing, drinking from a variety of cups, and reducing sensitivities because she did gag a lot. And that really was a big barrier for her to be successful with adding new foods to her diet. She progressed really nicely and ended up learning how to chew soft foods like cereal bars and fries, as well as transitioning to a more age-appropriate cup.
So Katie Stevens, Jen mentioned the connectivity with OT. Let's talk about the role of OT in this kind of case. Oh, you're muted.
As Jen said, our roles really overlap, but OT in particular, we will look at the child's whole body. We want to make sure that the child is able to sit up well, feel supported. If your body's not supported, you're not going to be able to eat your best. So for this child, we made some modifications to her seating to make sure that she was in a great position with her hips, ankles, and knees at 90 degrees and well supported. And then I also really look at self-feeding. That was a big goal for this family. And because of the motor impairments, we trialed some adaptive utensils to see if we can make that task a little bit easier for the patient.
And Sarah, now let's discuss the role that behavioral psychology plays.
So in behavioral psychology, we're looking at the behaviors that happen during meals that are interfering with eating. More specifically, we're looking at refusal behaviors such as turning away from the spoon or the food, pushing it away, maybe also crying or spitting the food out or holding the food in the mouth without swallowing. So first, we're looking to see, what do the meals look like? What are the routines at home? And then we like to identify potential reasons for why the child might be refusing after ruling out medical and skill factors. So to do this, we get information from the parents and caregivers, we observe the meal times, and then we might directly assess how specific and common environmental mealtime factors influence refusal. So do certain factors lead to more or less refusal? And then we'll develop individualized treatments with the goal of increasing acceptance of food and decreasing refusal. So in our specific feeding program, our approach is based on applied behavior analysis. So we're really looking for things that we can change in that child's environment to help motivate them to eat. So for example, we might change things about the food by making the bite sizes smaller or changing the texture. We may also change what happens after the child eats the bite. So maybe they get enthusiastic praise or they get to take a break with their preferred toy after taking bites. Often it's a combination of things that work for each child. And then we'll gradually and systematically increase the bite size and the bite number, and then we'll add in more foods as the child is successful. And then we train our caregivers and we'll do meals in other settings like the home or different areas around the clinic, just to make sure that the child's progress maintains in other settings with other people. So for Allison's case, we really were looking to find ways to motivate her to eat the foods that she had the skills to eat, but didn't have the motivation to eat. So we started treatment with her based on purees and using oral motor recommendations. We also started with small bite sizes for her. After she was consistently accepting bites, we really very gradually and systematic increased the size of her bites and then slowly the total number of bites that she was eating in collaboration with the rest of the team. To prepare her for that swallow study, we arranged the room to be similar to the swallow study setting. So we had the lights dimmed and we had white noise just to prepare her for that. And then after the study, we continued working with the team to gradually increase her volume and add new foods. And then we trained both her dad and her mom in meals. And then we were able to do meals around the clinic and in each of their homes to make sure that her progress maintained.
Yeah, I think that case really captures extremely well how complex the problem is and why no single discipline is going to be able to, in isolation, tackle that complexity. Clearly, many factors to consider. So, Katie Stevens, let's turn back to you. Let's talk about typical oral motor and feeding skill development in childhood. What is typical? Is it an age issue? Are there developmental milestones? How do you look for readiness?
That's an excellent question. When we're looking at the development of feeding skills, we don't like to focus on the patient's age or the child's age, because just like with every other skill, feeding kind of develops on its own timeline and is unique to each child. But what you do like to look at is where the child's overall development is, and are they kind of falling in the same line? A lot of people would be surprised to know that feeding and swallowing actually starts developing in utero as early as the first trimester, when the baby starts to practice sucking and swallowing and breathing, and that refines over time up until delivery. This is why Dr. Malakas had mentioned our premature babies are often already at a disadvantage when they're born, in addition to the host of medical issues that they may have. But for the first 6 months of age, or until a baby can sit unsupported, we're really looking at mainly breast or bottle feeding. And then once the baby can sit unsupported for several minutes without the assistance of a parent or a chair, they're usually ready to start trying some puree foods. They also might show readiness signs like watching a parent or a caregiver while they're eating, reaching for their food, trying to bring things to their mouth. When baby starts to crawl a little bit more, we're really looking at introducing some of those early finger foods. These are foods that when you put them in your mouth, they either melt with just your saliva without too much chewing, or they can be mashed with the tongue instead of using chewing skills. So examples are things like puffs or bananas or avocados, those very easy foods. And then gradually, as the baby starts to walk and gets more stable with walking and learning to run, they're ready to start eating harder foods that do require that chewing.
There's this term out there, Katie, that called baby-led weaning. What is it? What are the benefits and drawbacks of it? And how do you know if a child is appropriate for baby-led weaning?
Yeah, that's another great question, and one that we get a lot of the time in our clinic. Baby-led weaning follows a idea that you follow your baby's cues and kind of put them in the driver's seat, so to say, when they're eating. They are going to skip spoon foods. They're going to feed themselves. And the ultimate goal is that as they're able to feed these foods, they're already eating the family foods from the get-go, and it can lead to perhaps a more adventurous palate, and maybe avoid some of the picky eating. And the thought is that we skip those periods because as adults, we don't eat a lot of those foods. There are some positives to baby-led weaning, including baby is self-directed from the beginning. It leads to independence. It often leads to a positive mealtime experience between the caregiver and the baby. And they're exposed to a diverse amount of foods, and often it's the foods that the families do eat from the start. There are some drawbacks, though. It needs to be done safely and correctly. We need to make sure that the child is developmentally ready for the foods that are being introduced, or that they're given in a form where they don't pose a choking hazard. So it may not work for every child. We do want to make sure that the child is ready for this approach, but it can work for many children if that's what the family chooses.
So Jen, turning to you, obviously swallowing is key, but what are some of the signs that you look for in a child when you're concerned that there might be a swallowing problem?
So signs may differ depending on the age of the child that we're talking about. With babies, we look for signs of distress. So their fingers splaying outward, color changes under their eyes or around their lips, coughing, arching, or even frequently unlatching to the breast or bottle to try to coordinate their suck, swallow, and breathe. If these are signs you're noticing with your baby, consultation with a professional would definitely be a good idea. As children age, the symptoms are similar to what we look for in adults. So that could look like coughing, watery eyes, change in vocal quality, almost sounding wet, or even frequent upper respiratory infections, but you don't really know how you're getting sick. It is important to note that we all experience liquid going down the wrong pipe here and there, but these signs repeatedly occurring during mealtimes is a cause for concern. This could be due to structural differences or trouble swallowing certain textures and may require testing like an X-ray while eating or even a referral to ENT.
Yeah, so there are these terms that we use, gagging, choking, and aspiration. When are these phenomenon cause for serious, let's talk about the differences between them, and then when are they, concern?
So let's start with gagging. It's a sensory response that is protective in nature. So it's supposed to prevent us from choking or prevent us from eating something that's potentially harmful. It is a reflex that we're born with, but with repeated exposure and typical development, like hand to mouth exploration, toy to mouth exploration, and introductions of solids at the appropriate time, should naturally reduce your child's gag reflex. If this is something that's persistent, that keeps happening with new foods or at every mealtime, that's when you would seek out an assessment. Choking, on the other hand, is an actual blockage of the airway. You typically will not hear any sound, any coughing, and you will see signs of facial distress. This is not something we expect to happen frequently, so it is something you should bring up to your physician if you're noticing it. And then aspiration, we did briefly touch on before, but it's when that food and liquid goes down the wrong pipe and actually enters your airway. Coughing could clear it, but repeated occurrences could lead to lung disease, which is why we take it seriously. It is important to point out that some people may aspirate without those signs that we've described, so the coughing, the watery eyes. So if this is a concern, an assessment by a speech pathologist or an occupational therapist is important.
So Katie Davis, turning to you, when should caregivers start to bring their feeding concerns to the pediatrician? What are some of the red flags that parents and other caregivers should be looking for?
Yeah, so all of our disciplines are kind of looking at different red flags. In terms of skill development, it's really helpful to know this expected oral motor trajectory that Katie and Jen just went through, so that you can be curious if your child maybe isn't progressing through that timeline as you would expect. So, for example, if we have a 12-month-old child who is persistently thrusting food out of their mouth with their tongue, or very persistently gagging on a certain texture, it's worth bringing that to your pediatrician or seeking out some sort of oral motor therapist to look into what's going on. Growth is also a really big one. That's a big one that I look at. If your child is not eating or drinking enough to sustain normal growth, that's a big red flag for us, because we also know that can be a vicious cycle. When we have poor growth, we don't have as much energy to eat, and then it can kind of worsen growth. Variety is less cut and dry than something like growth. So like Dr. Malacosta went over, we know pickiness is a developmentally appropriate stage. But when does it become a red flag? So a 3-year-old who maybe used to love carrots, but for the past 2 weeks won't even like carrots, won't even look at carrots. It's offensive that you would present them with carrots. However, they still will, I'm sorry, I should have started. Let me start my example over. If we have a 3-year-old who eliminated carrots, won't even look at carrots, and does not accept any other fruits or vegetables, only wants crunchy snacks, that child would warrant an evaluation, versus a child who is not into carrots right now, but still lets them be on their tray, will be around them, and eat a variety of other fruits and vegetables. That would be a little bit more atypical to me. We're also looking at how the child's feeding is impacting their family's lives. So can the family go out socializing in the community and do things that they need to do in the community without having to constantly think about their child's feeding?
So sticking with you, Katie, what are some general strategies that parents and other caregivers can try at home if they are seeing these feeding behaviors that are of concern to you, but don't necessarily reach the threshold of seeking professional help?
Yeah, so my first recommendation is almost always going to be to offer a variety of foods. And if your child maybe doesn't seem to like a new food, to try and try and try again. Because one, we don't want our kids learning that if we react a certain way to a new food, that food kind of disappears from my repertoire or isn't really presented to me again. But two, we know that it takes many, many exposures to a new food for a child to decide if they like it or not. And so keep serving it. That being said, we do want to make sure there are 1 to 2 foods at each meal that you know your child likes, at least for that day. You know your child likes or is interested in, so that they can get nutrition, they can get energy, but they also have an opportunity to explore maybe a new or non-preferred food without the pressure to have to eat it. I think realistic portion sizes can also be really helpful here. We see a lot of kiddos who come in for an evaluation and are often just presented with these adult size portions of foods and are very understandably overwhelmed, and don't even want to eat foods that they do like. And so a good rule of thumb that I like to go by is for kids under 5 specifically is 1 tablespoon of each food group for each year of age. Um, so, for example, if we have a 2-year-old and we did a meal, we would focus on 2 ounces of protein, 2 ounces of starch, 2 ounces of a fruit, and 2 tablespoons of vegetable. I meant tablespoons. And then grazing is also a big one that I like to touch on. We want children to be hungry when they come to meals, so just making sure that there are kind of set meal and snack times with a period of time between eating occasions to, again, promote hunger. And lastly, I will always plug the necessity of regular soft bowel movements in a child's feeding journey, and you can work with your pediatrician to achieve this.
So Sarah, let's take that question about strategies from a behavioral psychology perspective. How do you address that?
Yeah, so a good starting point is to first look at the mealtime environment and create a mealtime routine for your child. So starting with seating, if your child has difficulty staying at the table for periods of time, so maybe they take some bites, leave, come back to the table, a good goal could be to just start working on staying seated at the table during meals for longer periods of time. So if your child's willing to sit for a short period of time during the meal, we want to start with a time that you think that they're going to be most successful sitting for. So if they're willing on average to sit for 3 to 5 minutes, you could start with 3 minutes and then kind of gradually work up to higher times. And then for some kids, using a timer for things like this can be helpful just because it's more like a visual signal or a visual prompt for when the meal is done. And then how to increase. So it really kind of depends on your child. You know your child best. So for some kids, you could increase by a minute. For some kids, it might be better to start smaller and increase by 10 seconds or 20 seconds. And then if your child's not willing to sit at the table at all during meals, a good goal could be to just start with sitting at the table for periods of time with preferred activities and then gradually increasing the time that they're sitting. Again, using a timer could be helpful. And then for some families, we hear that meals can be very, very long, so over an hour or 2, and often it's due to refusal. So setting a time limit for meals could be helpful for some kids just to help avoid lengthy meals that are due to refusal. And then talking about that refusal behavior, so the pushing the food away, turning away, we want to try to avoid giving attention for those behaviors. So like, oh, don't worry, it's so good, or don't throw the food. Even things like eye rolling, just because these types of attention can actually increase the likelihood that your child might refuse. So your child might start refusing more to get your attention or to get that feedback from you. So instead, if your child's refusing, you can redirect the conversation, talk about something else, or just redirect back to the meal. And then we want to provide praise for those appropriate behaviors that you want to see more of. So staying seated for the meal, taking bites, and self-feeding. It can be helpful to make your praise very specific to what you want your child to do or what you are happy that they did. So for example, instead of saying great job, you could say great job trying your bite of peach, just so it's more specific for your child.
Yeah, it's such great advice. It's the behavior being addressed as the child, but it's also really the interaction between the child and the parent or caregiver. So Sarah, sticking with you, a lot of parents and caregivers likely here tonight might be wondering how they can encourage their child to try new foods. What are some of the strategies that they can implement to try to increase the variety that their children are eating?
Yeah, so a common strategy that we hear that families might try is hiding new foods in the foods that their child's already eating. Although this might seem like a great way to sneak in some more veggies, your child might then start refusing that food just because it's been paired with the food that's new. And that could just limit the variety even more. So we generally recommend staying away from that strategy. However, when offering new foods, it's good to start with small bite sizes and just a few or small number of bites. So, for example, it could be one pea-sized bite of peach or a half a spoonful of yogurt. Starting with smaller bite sizes and fewer bites could potentially just help increase your child's willingness to just try the food. We also want to try to avoid persisting and feeding your child the bite by trying to maybe quickly sneak it in their mouth if they're refusing or crying. We don't want it to become a battle because this could make refusal worse and could just make the mealtime more stressful in general. And it could be helpful when you are offering new foods to start with foods that you think might be easier for your child to try. So, if vegetables are a food group that your child's not currently eating, and you might think that might be the hardest food group, maybe don't start with those foods. So, if your child's maybe eating some fruits, you could start with that food group, or maybe a food that they used to eat but no longer eat. You could also get your child's input on this. So maybe your child can tell you if a food is easier or harder to eat, and you can start there. And then for some kids, offering new foods during regular meal times can be helpful. So putting it on the table for them to try, offering it to them. For other children, though, offering foods during meals could lead to them refusing their preferred foods. So for these children, we recommend offering new foods outside of their regular meal times. Whenever you are offering new foods, it's important to make those expectations very clear for your child by giving them a certain number of bites and then to eat those bites within a certain period of time. So, for example, it could be 2 minutes to try one bite of banana. You could also use a timer to kind of help your child. And so they know how much time they have. And when the timer goes up, that means we're done. And then if they don't try the food within that time frame, you can just remove the food and move on to the next activity. That way the session ends based on time and not based on your child refusing. And then for some kids, having choices could help increase their motivation. So instead of saying, do you want to try this or not? Because most often they might probably say no, but it could be that you give them the choice between different foods to try. And then if any of these strategies are successful, you can gradually increase the bite size or the bite number. And then just want to throw this out there as well. If refusal worsens after trying any of these strategies several times across different foods, we want to stop using those strategies and then reach out for help if you have concerns, just because, again, we don't want the mealtime to turn into a battle.
So, Christina, turning to you, of course, there are going to be situations that really are not appropriate for our pediatric feeding disorders program. So what kind of feeding concerns would you recommend not come our way? And if it's not a good fit for this feeding disorders program, how should a parent proceed to get help? And along the same lines, how do families who have a feeding concern that they'd like us to evaluate take that first step?
Yeah, absolutely. So there are many different situations that cause caregivers to be concerned about their child's feeding difficulties. A few examples of the challenges that we do not treat are body image concerns, such as anorexia, bulimia, or binge eating. Pica, which is defined as when children eat non-food objects such as paper or coins. Rumination, which is a behavioral disorder characterized by the automatic vomiting of recently eaten food. Children with uncontrolled seizures, as seizures must first be well controlled before we can target feeding difficulties. Children who are dependent on total parental nutrition. Children with chronic pain disorders, as that pain must first be well controlled before targeting feeding difficulties. And children who have been told that they should not eat by mouth or have a recent swallow study that shows that food or liquid goes down that wrong tube. In addition, we do not treat individuals over the age of 18, and if your child is younger than 18 months of age, they will be referred to a speech or occupational therapy evaluation. Lastly, for children with extremely high rates of aggression or self-injury behaviors, we recommend that they first participate and graduate from a neurobehavioral type of treatment before being seen in our feeding program. I outlined some of the main concerns that are not treated in our program. However, this is not an exhaustive list. We encourage families to talk to your pediatrician if these concerns are present, because it doesn't mean that there isn't help for you. It simply means that the Institute's Feeding Disorders program is not the right option for you. If your pediatrician has questions, whether it be if your child is an appropriate referral for us, or if they want to know sort of where the appropriate clinic may be for your child, we encourage your pediatrician to reach out to us for collaboration. So we've gotten this far, and parents are now likely wondering how to get in touch with us if they have concerns for their child's feeding difficulties. We encourage parents to navigate to Kennedy Krieger Institute's Pediatric Feeding Disorders webpage. On the main page to the right, caregivers will see Make an Appointment, where you can complete the online intake form, or you can call us at 443-923-7508. Once your child has been cleared by our intake coordinators, your child will be seen by a multidisciplinary team consisting of 4 providers. One is a GI provider or a nurse practitioner, a nutritionist, a behavioral psychologist, and a speech language pathologist or an occupational therapist. At that appointment, we take a detailed medical history and we conduct a small meal observation where your child will be offered both their preferred and their non-preferred foods. Afterwards, the team will discuss with you the best treatment option for your child based on that appointment.
So thank you, everyone. We've really covered a lot of issues, and now I think we have a good amount of time for questions, maybe 15 to 20 minutes or so, to answer some of the questions that are coming in from our audience. Now, a note before we start: we really can't assess the issues of specific patients via this webinar. That would really require us fully evaluating a child. So if questions that are coming in are targeted for an individual, please consider the responses general principles based on the little bit of information coming in, and not a true assessment or recommendations for a specific child. So we're best suited to speak to really general questions. I've been getting questions starting to come in, so let's dive in. And I'm going to ask our panelists, if I don't identify exactly who you should go to, just raise your hand and volunteer. So let's take the first one. I'm going to ask Michelle to take this on. At what age should we start looking out for feeding disorders?
So I don't think there's a particular age, right? It's, as we talked about, feeding behavior starts really early. Typically in an infant, a feeding disorder might look like a refusal to latch on, or an inability to latch on to a breast or bottle, refusal of a bottle. So that could be a feeding disorder that develops at quite an early stage. As they go through that normal developmental trajectory, as Katie says, it isn't specific ages, but there are windows where we like to see things. So typically around 4 to 6 months, babies should be interested in purees, should start being able to take them in instead of thrusting them out. So certainly if you have a baby who's getting close to a year of age and still isn't able to do baby foods, that would warrant a concern. So really there isn't, at any age, a child could present with a feeding disorder, because I would just define that as any child whose feeding skills and behaviors aren't where you would expect them to be based on their age, but also their other motor and social development.
Okay, next question, I think for Sarah. Do all the kids that we treat in the Pediatric Feeding Disorders program get better? Do some kids just never eat, or make sort of incremental progress? What are the outcomes looking like?
Yeah, that's a really great question. So getting better is kind of relevant to each child. So each child comes to us with a very different presentation in terms of like their eating history, their medical history, where their skills are at. And so really we set really specific and individualized goals, feeding goals for all the children, and they kind of vary based on the child's needs. So we might set a variety goal, or we might set a self-feeding goal based on oral motors recommendations or an oral intake goal. And so the goals that we set vary, but just looking at some of our data that we have, and you can also find this on our website, but just from our last year in 2022, 88% of the goals that we set across children were met by the end of their treatment course. And then 96% of our families who completed the program for their oral intake goals specifically, they all met that goal. And then we also had for our food variety goal. Now, again, this is really dependent on the child. So it could be increasing it by 6 foods, or it could be by 16 foods. And so we had 93% of patients meet or exceed their food variety goal last year.
So we need somebody to volunteer for this one. So let's think about a scenario where a school-age child only eats 3 different types of foods. How do you discern, is this child ill or, let's say, quote unquote, spoiled? How do you approach this? What do you recommend families do in this situation?
Yeah, that is definitely a child that I would think warrants a conversation with your pediatrician. Typically, even picky eaters will usually be able to find something to eat in most situations. So a child whose varieties that they eat are so limited. I mean, if it's really truly 3 foods, right? That presents a risk of missing huge categories of nutrients, even if they're getting in enough calories. So for example, a number of years ago, we had a child admitted to the program who would only eat white bread and white plain pasta with nothing on it, and was actually gaining weight, right? Was getting enough calories, but had vitamin D deficiency, vitamin C deficiency, had anemia, didn't have enough iron. So you can see when you're limited to that extent, that could be really unhealthy. So that is definitely a situation where I would have that child evaluated by the pediatrician, get a really good food history, really watch what the child eats. The child might only eat 2 or 3 things at a meal, but be grazing on other things throughout the day and might be doing better than we think. But that child definitely warrants an evaluation.
I think this one is best for Sarah, but you guys can redirect me. Let's think about a school-age boy, well-grown, no obvious problem with physically getting food in, has some developmental learning issues and other neurocognitive issues, and has always had behaviors around food of impulsively smelling or compulsively smelling the food or toys. He has limited variety of foods. How do you think about the pathway of picky eating or feeding disorder? And is this an age that we would take into our feeding disorders program?
Yeah, that's a great question. So I think we'd probably want to get a little bit more information about what that child is eating, but kind of going along with the theme of, is it interfering with the child's ability to socialize in meals? So are the parents having to make a meal for them and a separate meal for the child? Often that is the case when kids are young because their palates are, limited to certain foods. But it kind of just depends too, if we're talking about like going out, is that an issue where we can't find anything that's available in community settings? Or is it interfering, like is the child missing food groups? Also looking at the specific behaviors that we're seeing during meals. So maybe smelling could be a way of just making sure that it's the food that they know or the food that they like. So sometimes we see kids have very rigid mealtime routines where they like a certain food. It has to be a certain brand because that brand is predictable. They know exactly what that brand is going to taste like and that food's going to taste like each time. So sometimes it could be that we're just kind of looking to see more what the routine is. And then in terms of what the child is eating, the variety, this would be another case where we'd want to get more information to see if that child would need some sort of evaluation.
Jen, I think this one's for you. Do speech delays and feeding disorders go hand in hand? Do they correlate with each other?
Quick answer, no. But if you take into account overall development, you may see general developmental delays with children who also have feeding disorders. That is a risk factor for feeding disorders. But I have had patients who have no problem with speech delays, but have difficulty chewing, and then vice versa.
Christina, you're up for this one, I think. Once the intake call has been completed, how long does it take to get in to be seen?
Yeah, so our wait list sort of varies, but right now it's just a few months. But we typically have like last minute cancellations and that kind of stuff, so we can get kids in. I would say within a few months.
And sticking with you, Christina, if your child is already diagnosed, or if a child is already diagnosed, say elsewhere, can they still get help from our program?
Absolutely. Absolutely.
Yeah. That's a nice, quick and easy one. That's right. I think we could go to Michelle or Christina on this one. Are these evaluations of programs generally covered by insurance?
They are typically. So most insurers, including medical assistants, including TRICARE, including most commercial insurers, do work with us. We have had times when insurance companies have questioned the need for, if we recommend, for example, an intensive feeding therapy, whether that's inpatient or day treatment, sometimes they want to have a bit of a discussion to really understand why that's necessary. And so we have a conversation, either myself or one of the other providers can have a conversation with the insurance company to explain why in a particular case we feel that an intensive treatment program is in the child's best interest. And they're typically pretty receptive to that. So yes, almost all insurances will cover our evaluation, but also our treatment.
I'm gonna have to ask you all to suggest who's going to answer this one. Can you share more resources about food chaining? Katie Stevens, yeah. Oh, you're muted. You're muted.
Yes, and for those on here who may not know what food chaining is a way of introducing new foods to a picky eater that changes just one of the sensory properties of a food they already eat to try and get them to a more expanded diet. There is a book that's written for parents and caregivers, not for clinicians. It's got a really long title, but it is called Food Chaining. I think it's the Proven 6-step plan. It's on Amazon. It's very inexpensive. You can get it from any other book retailer that you'd like. I do believe there are some agencies that have libraries where you can input a food a kid's already eating and see some foods to go to, but they do charge membership fees, and you could do a basic internet search to find those.
Katie Davis, this one's for you. Do you have any recommendations for go-to foods that are easily acceptable by kids that have a feeding disorder? You know, for example, only crunchy, starchy food, or that are also nutritious?
That's a tough one. It also depends on how, brand specific a child can be. I think a lot of our kids can have success with the food chaining approach of trying to get to some sort of like freeze-dried fruit. They're often quite crunchy. It can give a lot of that feedback and input that a lot of kids are looking for. And then maybe can chain one day to a fresh fruit. I always plug trying to look for whole grain options for just like a little bit more, B vitamins and a little bit more protein. But the dry crunchy snacks are really hard and a very popular part of a kid's diet. A lot of the kids that we work with.
So this might be for you as well, Katie, but others chime in. It's kind of along the same lines. How do you encourage self-feeding in a toddler of nutritious foods?
Maybe I'll tag team this with Katie Stevens, but I think it really comes down to, not to beat a dead horse, but is presenting a variety. So, and with very limited pressure for the child to eat. You know, once your kid knows that you want them to pick up that piece of broccoli on the tray, they're not even going to look at it. So it's, you know, play it cool, present a variety, present it consistently. And I think you'll be surprised at, you know, how your child wants to interact with it. You know, or just try a new food through that process.
Katie Stevens, you want to chime in on that?
Again, picking the foods that are similar. If your kid only eats things like macaroni and cheese, I would not expect them to eat a bite of broccoli, but you know, maybe they'll eat cheesy potatoes. So kind of picking foods that are very similar to the preferred foods. And then for the self-feeding piece, as long as they're kind of developing on target and there's no fine motor concerns, there's no need to change the utensils or the dishes you're using. You can use whatever the family prefers to use for the child. If you do have a child that's having a little difficulty controlling a spoon or a fork, I tend to recommend utensils that are shorter and wider on the handle. They're a little bit easier for small hands to manage.
Sarah,
I'd
go
like
ahead.
to just chime in real quick.
Yeah.
So, adding to that, so if the child has the skills, but maybe it's a motivation, so maybe they're willing to self-feed other foods, but it's just certain foods. You could start, I think praise could be something if your child enjoys that. So praising. Sometimes doing the full picking up the spoon and bringing it to my mouth is a lot of work. So you could start off by that maybe you're doing part of the self-feeding process. So maybe you're helping it to their mouth and they're taking the spoon out on their own and they get lots of praise for that. And then gradually working up so that they're doing the full process by themselves. So that could also be helpful too, is just breaking it down into smaller steps to see if your child's willing to do part of the step of self-feeding, and then you can build from there.
Sarah, sticking with you, there's actually a roster of questions that I think are right in your space. So let's think about a 1-year-old who used to have a variety of foods, loved them all, and now throwing foods when they're not preferred, and it has now generalized to throwing all foods. How do you think about this sort of an issue? What are the next steps for a parent to consider?
Yeah, so I think there's a couple things potentially going on. So one thing to think about is if they're doing it with preferred foods, I'd be curious to know when it's happening. So is it maybe that they start eating their foods and then they're at a certain point in the meal where then they start throwing? Because maybe it could be that that's turned into a way for your child to signal, I'm done eating or I'm full. And so they start throwing the food because maybe that's just easier for them to tell you that they're done. Also, for some kids, it could just have turned into a game. So maybe they started with foods that they don't like and they realize, oh, this is fun to do, or mommy gets upset when I do this and it's funny. And so trying to avoid attention and not having a big reaction for those types of things can be helpful. And then also it also could be that maybe it started with foods that I don't like. So I'm throwing them because I'm telling you I don't want them. And so just trying to redirect. So it could be just maybe we don't make a big deal out of picking up that food, but we just kind of move on to the next bite as well. And then also if it is something that as soon as you put it, let's say they're in a high chair or something, as soon as you put it on the tray, that's when the food goes flying. Maybe just don't have it in their reach, and you could start with small bites at a time instead of having a full plate in front of them. That way they're not throwing a full plate of food and it's maybe a couple bites, and you could start there. Another thing could be to just help them too. So we were talking about maybe they're not motivated to self-feed, maybe helping them with the eating could be helpful, and then giving praise for taking their bites. So if they're not throwing their foods, we don't want to say good job not throwing, but we could say, oh, great job taking your bite, and kind of turn it so we're praising those appropriate behaviors.
Sarah, sticking with you, this is I think a really important question. It's how do behavioral analysts work with parents to make sure that the treatment approach that you work on, say in the office, is going to generalize to working at home?
Yeah, that's a really great question. So we really start talking to the parents and getting an idea of what the home looks like from the very start of the child's treatment course. So initially we're looking at what is the mealtime setting? What is the child sitting in at home? Are there other family members around? So sometimes it might be that, when we're doing treatment, we have these really nice clinic rooms that are not very busy, they're not loud, but at home, it's not necessarily like that. So sometimes, often to start, it's really just we need to work on first increasing the child's motivation to eat where they're consistent. And then oftentimes it's sometimes just the caregiver starting to feed. We might see the child start refusing again. So we try to work through that first. And then with other settings, we really try to start in other areas of the clinic or have the clinician out of the room first. Sometimes for kids, it's just the mealtime setting. So just being in my kitchen or my living room, we need to kind of work through that. So we might set up the room to be similar to the home. We may also do it in different areas in the clinic that look more homey, so not necessarily our treatment room. And then we also for kind of busier environments. So if the family tells us, oh, we do family meals and I have to eat too, and I have 2 other children that are also eating, we'll try to do family meals. So maybe if we can bring in the siblings at that time, we'll do a practice meal, or we'll do a meal with the parent eating so that they can have experience of eating themselves while also implementing the treatment with their child. And so we do from the outset kind of talk to the parent, what do you think are going to be some barriers? Sometimes they don't know until they see the treatment. So we're always constantly in communication with the parent, and making sure that we can set up the mealtime environment in a way that best supports their child, but still not having them do all these things to set up the room, but it could be just, can we arrange the chair in a different way to provide support? So constant communication throughout the child's treatment course to make sure that we're preparing for the home, because really that's going to be the key. It's great if they're eating with the therapist, but really the ultimate goal is for them to be eating with the families and eating in their homes.
Yeah. So Michelle, you're up next. Can issues like enlarged adenoids, for example, cause feeding disorders?
So we definitely do see kids who have issues with swallowing related to concerns such as large adenoids, allergies, tonsils. I rarely see that progress to a true feeding disorder, but I will say it is one of the things we try to kind of rule out. So if we have a child who particularly has difficulty with swallowing certain textures or certain volumes, and we do notice that they have bigger tonsils and adenoids, that's someone we may have ENT take a look at. But I have not commonly seen that by itself lead to a feeding disorder.
Christina, I think this is back to you for sort of programmatic considerations. Where can we find programs like this if we don't live in Maryland, but maybe if you can't come here? Are there other programs or other ways for us to see somebody remotely?
Yes. So depending on where you are, because we see children from all over the world, it will sort of depend. So you can, and again, it depends on the severity of that pediatric feeding disorder. But so some children may just do outpatient oral motor therapy with a speech language pathologist or an occupational therapist that has training in feeding. So that's sort of the key there. There are other programs that do target feeding concerns. So it just depends on sort of the location, and we are certainly happy to help parents in those situations.
Another question related is for Christina is, do we have any satellite locations for the feeding disorders program?
So for Kennedy Krieger, everything for the feeding program is located in Baltimore.
Yeah.
Mm-hmm.
Michelle, back to you. Oh, go ahead, Michelle.
Can I tag on to that?
Yeah.
So one of the things when you talk about other programs, Brad mentioned when he was doing our introductions that Jen is on the board for the IAPFS, which is our National Association for Pediatric Feeding and Swallowing, and they are a great organization as well. So we can certainly include their website in the resources that we send out after this talk for people who are interested. But we and many other feeding disorders programs are members of the IAPFS, and that they're just a great resource for nationwide. Sorry, thanks.
Michelle, stay on, because one of the questions is about kids with severe allergies. Is that a situation that might come into the feeding disorders program, food allergies?
Yeah, absolutely. So there's a couple of issues around allergies that we see. One is that particularly in younger children, when they have multiple severe food allergies, and so that makes choosing palatable foods can become really challenging for parents, particularly if it's an allergy to some, really common staple food ingredient. Like if you have a child who's allergic to dairy and wheat, that's going to eliminate a lot of common foods. They're not going to eat pizza. They're not going to eat, macaroni and cheese. So a lot of really kid-friendly foods are going to become challenging. And so those kids can have real challenges with getting in adequate variety in ways that are palatable. The other situation where we see that is with kids who are a little older. One thing we haven't touched on a lot tonight is people may have heard of something called ARFID, which is Avoidant Restrictive Food Intake Disorder. And that is a diagnosis that we often see in older kids. And by older, I mean school age as opposed to preschool. And it's often associated with a triggering event. So a child who has, for example, an anaphylactic allergic reaction to something that they eat, who then develops anxiety about eating that food, but then that generalizes. So they get worried that, well, I ate that blueberry pie and I had this horrible reaction. Maybe any other kind of fruit is going to do that. And so I better just stop eating them. And these kids can become so anxious that they can really shut down, not only from food, but even taking in liquids. And in fact, we've had kids who won't swallow their own saliva because they've just had such a negative experience at some point. So food allergies are not the only trigger for that. Choking episodes, other kinds of symptoms have been identified as triggers for ARFID, but food allergies can definitely be one. So that's another way that food allergies can impact eating disorders. When we do have a child who has food allergies, who gets admitted to the program, that again just points out the importance of having a nutritionist on the team who can review all the foods that we might offer to be sure that those allergens aren't hiding in anything that we're feeding them, and making sure that the child stays safe while they're with us.
Here's a question I think is for Katie Davis, but others may chime in. Any suggestions on how to hide nutrients in the foods a child will eat, and it's a good approach to even try?
Yeah, that's a great question. So my response might be discouraging. However, we really do not suggest any sort of hiding of a food in another food. And the reason for that is we work with a lot of kids who are very selective and eat a very limited variety of foods. And if that food is kind of tampered with, maybe one time it doesn't taste like it should or like they're used to, that can lead to kind of a sense of distrust, and they can eliminate that food and they don't really want to eat that food anymore. And then you kind of have more problems, besides the fact that they wouldn't just take in what you wanted to hide. You could lose a pretty trusty or safe food. So we really actually discourage hiding. So I guess my answer would be to kind of supplement where able and where appropriate with appropriate multivitamin supplements, and trying to make your child aware if there are small changes. If you're trying to really boost the protein content of something, and you're just adding peanut butter to it, I would just make it clear. So there isn't that surprise factor.
I think this is a question for Jen and Katie, but you guys tell me otherwise if I'm wrong. consider a 5-year-old with trisomy 21, also known as Down syndrome, who doesn't chew. Parent makes special foods at home. He's currently seeing a specialist in this area, but the question really is this an appropriate kind of referral for the program? He has lives out of state in the region, though. Is this the right kind of a consideration for this child? Jen.
So I think you would first think about the skill and if there's a skill deficit going on. So you have to make special food, right? So that tells us that you need a speech pathologist or an occupational therapist for support there. This is a case where the skill deficit may merge into behaviors over time, where our team may be a good approach because we're able to bring in skill and behavior and treat it simultaneously. Thinking about our nutritionist team as well, of knowing how to increase the texture of the food while also maintaining like adequate calories is important. So this would be a really good example if there's behaviors within meal times of a case that we could treat as a team.
ADS, did you want to comment, or that covers it? Great. So here's a great question. What about the modeling from how parents eat? This member of the audience says, my husband lives on snacks and soda. Is that going to influence the way my child eats? Sarah? Or Katie? Either. Sarah.
Yes, it will. It absolutely will. I think, when we're offering a variety of foods to our kids and they don't see us or anyone around them eating, it is not really a reasonable expectation to then expect them to start eating it.
Christina, about how long typically might a treatment course last?
So all of that's going to be individualized. So we do have different levels of just outpatient therapy with a behavioral psychologist, or it can be with an occupational therapist or a speech language pathologist, or we can co-treat as well. So that is a little hard it's not cut and dry. For our day program, which is an intensive 8-week program, that is Monday through Friday. And so, as I said, that is an 8-week program. And then we have an inpatient program as well. And typically, again, that is 8 weeks as well. I think it's just important to note, though, that depending on the goals that parents have, or depending on the skills or the variety, the texture, there's a lot of different variables of when that child sort of may come to us. We may not fix everything in 8 weeks, and that we may even need therapy after the 8-week course. So it's all individualized. It's really hard to say.
Well, I have to say that the questions have been excellent and really thought-provoking for all the panelists. I know I could see it on everybody's faces. So thank you all for that. That's all the time we have for this evening. We are going to be sending an email to registrants with contact information for our feeding program, as well as information about our resource finder services and other useful information, including a link to the recording of this webinar. One of the questions that came in, an excellent question: can the recording of this webinar be translated into Spanish? The answer is yes, and we will get on that as well. I think it will be transcribed, but thank you for that question as well. I'm sorry we couldn't hit every single question that came in. We just are bumping up against our time. We are so glad you joined us this evening. Thanks for sharing your time with us. We hope you found the webinar valuable. Kennedy Krieger offers free Exploring the Brain webinars about different topics of child development on a regular basis. You'll receive this email asking for your feedback in a few days. We'd love to hear from you and hope you'll plan to attend a future webinar, future Kennedy Krieger event, consider volunteering, or perhaps becoming a donor. Thank you all and have a wonderful evening.